Hi, I'm Dr. Benjamin Levy. I'm a thoracic medical oncologist at Johns Hopkins School of Medicine, and maybe we can just go around the room and introduce one another.
My name is Dr. Wally Kern. I'm a radiation oncologist. I'm the Chief Medical Officer for Genesis Care, and I'm also Professor Emeritus at Emory University.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Radiology and Vice Chair for Education at Memorial Sloan Kettering Cancer Center. And I'm also a Professor of Radiology at Weill Cornell Medical College.
Mike Lanuti. I'm a thoracic surgeon at Massachusetts General Hospital in Boston. I'm the Director of Thoracic Oncology for our Division of Thoracic Surgery. Also have an adjunct associate professor at Harvard Medical School.
I'm Ramaswamy Govindan, a medical oncologist with interest in lung cancer. I'm a professor of medicine at Washington University in St. Louis.
70-year-old male reformed smoker, 40-pack year, with at least a stage 2A, a T3N0 squamous cell carcinoma of the right superior sulcus, PD-L1 2%. PET-CT demonstrates a hypermetabolic pretracheal and right hilar lymphadenopathy with a negative EBUS. So PET positive, but EBUS was negative. What is the general recommendation for these superior sulcus tumors and a 70-year-old male, relatively fit patient? Trimodality? If so, what's the radiation dose and fraction? And then what do we do after neoadjuvant chemoradiation? If that what do we do after neoadjuvant chemoradiation followed by resection? Is there things to do after for these superior sulcus tumors? Patient presentation: cough, right upper extremity weakness and shooting pains. Performance status is 0. Medical history: osteoarthritis. He's a 40-pack year history, 40-pack year smoker, and he quit 5 years ago. He has no lung cancer history, colon cancer in the maternal grandmother. So I'm going to fast forward to the PET images. The CT scan shows a 6-centimeter soft tissue mass extending into the surrounding tissue of the right apex without involvement of the right subclavian. And then we have a PET, and I'm just going to turn to Dr. Ginsberg here to go over a couple slides here on the PET.
So the PET images demonstrate that large right apical mass, which measures almost 7 centimeters, and it's sort of like a Pancoast tumor, essentially, both on the axial and the coronals. And if you advance to the next slide, we'll see that there is right paratracheal and right hilar lymph nodes, which did have an SUV around 5, so they are avid. So there is contralateral lymphadenopathy along with it. And the MRI of the brain demonstrated no metastatic disease.
Great. Thanks, Dr. Ginsberg. So the patient has a CT-guided biopsy of the right apical lung mass. It's a squamous cell carcinoma. There is an interrogation of those lymph nodes that is negative for any cancer. Moleculars, not PD-L1, but moleculars aren't done, and the PD-L1 is 2%. Pulmonary function tests are shown here: FEV1 of 76%, FEV1 over FVC of 65, and a DLCO of 65% predicted. So Pancoast tumor, superior sulcus tumor, lots of data in this way back when. How do we manage these? And I think all the medical oncologist, the radiation oncologist, and the surgeon are clearly involved in these cases. I'll start with Dr. Lanuti, just your approach on this for these patients. If they see you first, you send them to the medical oncologist and radiation oncologist first. Is there a role for operating on them right away? Just your general approach in these cases.
Yeah, so I'd say a couple of things. One is that the only associated symptom I see with this guy is maybe ipsilateral right arm weakness that could suggest some brachiocephalic or brachial plexus T1 involvement, but otherwise I don't hear that he has chest pain, which is often the presentation, so bony chest wall pain. But the approach for these are, you stage them up, you would get a brain MRI for sure, and then this PET scan that shows the FDG-avid lesions in the pretracheal and right hilar. We know that if we offer surgery or trimodality therapy for these patients with superior sulcus tumors, that the ones that do the worst are the ones within 2 disease, and 1 disease would be less, perhaps a little less associated with the outcome, and 2 being the worst. So I think it's important for the practitioners to know that if there is an EBUS sampling of an FDG-avid node and it's negative, is that adequate? It is understood that if that node could be biopsied in a more meaningful way, mediastinoscopy is still the gold standard. So that at least the pretracheal node can be biopsied with mediastinoscopy. I would recommend that because again, N2 disease would be the deal breaker for offering surgery as part of multimodality therapy. If those were truly biopsy negative, and maybe they had some other thing like granulomas or sarcoid-like reaction, that would be more comforting. And then if you're isolated to that right superior sulcus, I would then refer to my medical and radiation colleagues to then move into a trimodality therapy. Sometimes I'll get an MRI to further evaluate up at the superior sulcus to see what other structures are involved. If the structures of the artery or vein are involved, we still can actually resect and reconstruct those, right subclavian. If the brachial plexus is heavily involved, that's a problem. But if one nerve root is involved, that's not a deal breaker for doing a resection with chest wall.
So great. So potential resection followed by some sort of induction treatment. You would refer them initially to the medical oncologist and radiation oncologist, Dr. Curran, and then Dr. Govindin, your approach on this and what radiation dose and fraction would you give to something like this superior sulcus tumor?
Yeah, so I agree with Dr. Lanuti that we really need to be clear. Those nodes that we saw in PET are highly suspicious, the SUV, the size of the abnormality. So I think they need to be interrogated before we go trimodality approach. This is a bulky tumor. The typical preoperative dose is 45 gray with chemo, concurrent chemo now. If we really feel like the patient's anatomy would enable surgery, then that's probably an okay dose. If we really think there's going to be a low likelihood of actually completion of surgery, there really has to be great coordination between the surgeon and the other doctors on this case. Not everyone has the pleasure of working with someone like Dr. Lanuti, so you really want to be sure you have a surgeon who's comfortable taking a case like that on before you just stop at 45 gray.
Great. Dr. Govindin, just chemotherapy. I think we've talked about this before. Your weekly carbotaxol here with the radiation prior to surgical resection?
The best data we have here is the studies done by SWOG and others. I would give, in this instance, I would give cisplatin-based therapy with 45 gray of radiation, like the way Dr. Curran said. I would use that regimen because that's not been tested. Also, it's worth keeping in mind that the Pacific studies of consolidation durvalumab or maintenance durvalumab did not include those patients who underwent surgery. So this would not be applicable to this. So I would treat it exactly like how we know we were successfully treated in the past. And the outcomes actually were pretty good in the absence of nodal involvement in these patients. And I would stick to that established regimen.
Would you consider, so some of the data that was generated and published on these tumors is consideration, or they did give consolidation chemo. Would you not give durva? Would you give chemotherapy post, concurrent chemo radiation followed by surgery, followed by additional 2 cycles of chemo, or just call it a day with the chemo rads followed by surgery?
I don't recall, and I stand to be corrected if I'm wrong. I thought these patients get induction chemo, concurrent chemo radiation and surgery, and that's it. Yeah. Dr. Karan and others can correct me if I'm wrong. I think I would stop after chemo radiation.
Yeah, that's what the studies are. Yeah. The challenge is if you don't get, a satisfactory surgical result, then, you sort of have to think about what to do then. And that's a tough circumstance that doesn't do well in general.
So just to summarize this case, it sounds like induction chemo rads, cisatopicide in this case, with radiation 45 gray, followed by potential resection, and that would be the optimal therapy for this patient with a superior sulcus tumor.